Go ahead. Welcome once again to Thoracic Gurus. I'm so happy to once again invite our dear friend, Dr. Vikas Keshri, who is a senior consultant in cardiothoracic surgery at Max Super Specialty Hospital, New Delhi. Uh, a really excellent teacher and contributing great to the education system, not just in India, but all over the world now. Because you're going to talk today to us about carotid artery disease. The floor is all yours.
Good evening, everybody. At the outset, I would like to thank our dear AGK sir to giving me this opportunity to be presenting here again on the Thoracic Gurus Forum. And today we are going to discuss topic given was carotid endarterectomy. Basically, we are going to discuss coronary artery disease and carotid endarterectomy together also, both the topics together also. So before I start, I would again like to thank all the places. These are the places where I have trained. So I would like to thank all my gurus who have imparted some of the wisdom to me. And it's a disclaimer. This is not how I do it series. It's a series what we are supposed to tell in the examination. So this is meant for quick revision for people who are going to exam or just before the exam or few days before the exams. So today we'll be discussing isolated carotid artery disease and carotid artery disease in combination with coronary artery disease. How are we supposed to go about it? So, stroke is the second leading cause of death worldwide after coronary artery disease. And of the strokes, around 84% are ischemic strokes and 16% are hemorrhagic. Out of these 84% ischemic stroke, more than 50% are caused by atherosclerosis. Some are caused by atrial fibrillation related problems, and others are caused by non-atrial fibrillation related cardiac causes, valvular heart disease and left ventricular dysfunction atrial. Of the atherosclerotic diseases, most common etiologic thing for stroke is disease in the extracranial carotid arteries. Other less common causes of carotid artery disease are fibromuscular dysplasia, intimal hyperplasia, and radiation injury. So these are the uncommon causes leading to occlusive disease in the carotid artery. Why it is important to treat it aggressively? Because 40 to 50% of patients with stroke will have a second stroke within 5 years. And around 30 to 40% of people who have a transient ischemic attack secondary to carotid artery disease, they will also have a stroke in the next 5 years. And out of the 30% stroke survivors, out of the survivors, 30% are dead in 2 years, and almost two-thirds, that is 65%, are dead by 12 years. So that is why it is important to treat. In those patients who have symptoms, 2 years risk is, then why we need to know this? This is the natural history of a stroke. So these things give us the guidelines to manage different categories of patients. So if the lesion is moderate, that is 50 to 69%, that is 22% risk of stroke in 2 years. And the moment this becomes severe, 70 to 99%, the risk becomes 26%. And those patients who are asymptomatic, there also risk of a stroke is 7.5% if the stenosis is less than 50%. But this stroke becomes almost three times to around 18% when the stenosis is more than 75 to 95%. So these natural history things tell us that even in asymptomatic patients, the severity of lesion increases. We need to intervene because the risk of stroke increases, and that stroke has some devastating results in future. Then comes coexistence of coronary artery disease and carotid artery disease. So atherosclerosis is actually a generalized phenomenon. It affects all the body organs, blood vessels everywhere. So what is the coexistence of coronary and carotid artery disease? So they exist together in 3.4 to 22%. This variation is there because different at different stages, different studies have studied the incidences. And then this also varies in among the coronary artery disease patients also. The incidence varies according to the type. So patients who are undergoing CABG, this series has reported 5 to 8% of patients have concomitant carotid disease. But moment the people are more than 65 years of age, so age more than 65 years is a risk factor for coexistence of this. 17% of people have coronary artery disease and carotid artery disease concomitant with coronary artery disease. And those who have left main carotid artery, coronary artery disease, almost 50% of them have occlusive disease in the carotids. So that becomes an indication for screening those patients who have left main disease or those who are older than 65 years. These people, when they are going to coronary artery bypass grafting, we must be careful and try to screen these patients to find out whether they have a significant coronary artery disease or not, carotid disease or not. So that comes then, what are other predictors which will tell us that we have a patient who has come to us with symptomatic coronary artery disease, and we are planning to do a coronary artery bypass grafting. So what are the predictors that this patient might have a significant disease in the carotids also? So there are multiple. Age more than 65 is a risk factor, not 55. Female patients, they are more likely to have coexistent disease in the carotids. Diabetics, hypertensive, smokers, and tobacco users, they are also more likely to have disease. The most common risk factors, any person who has a previous history of stroke or a transient ischemic attack, that patient has to be evaluated aggressively to find out whether that carotid artery also needs intervention. Because if we take a patient with significant carotid disease for coronary artery bypass grafting, chances of stroke are there. Any patient who has prior cardiovascular diseases or cerebrovascular diseases, any patients who had carotid endarterectomy, obviously he is a risk factor. Wherever on examination we find a carotid bruit, those patients we must evaluate in detail before embarking on the coronary artery bypass grafting. Any patients who have extensive peripheral artery disease, peripheral vascular disease, they must also be evaluated to find out whether that carotid also needs intervention at the same time or at a later date when we have a patient who has come for coronary artery bypass grafting. And we have seen that left main disease, almost 50% of people have
लेक्चर शुरू हो
coexisting artery disease.
लेक्चर
Uh,
जूम पे
then
वेडनेसडे के दिन 7 बजे से
why it is important? So if a patient has an if a patient has an is undergoing isolated coronary artery bypass, am I muted?
No, no,
So
no.
you are
No, yeah. So
you are
if the
audible.
patient, yeah, if patient has a is undergoing coronary artery bypass grafting, the incidence of a stroke is 0.7 to 5%. Some series. So for our practical purpose in modern day practice, we take it as 2%. If a patient does not have a carotid disease or any other predisposing factor for stroke, for all practical purposes, we take that there is a risk of a stroke 2% if patient is undergoing coronary artery bypass grafting. But if the patient also has carotid artery disease, the stroke risk becomes multiples. So it is 6% if the stenosis is less than 50%. And then moment the carotid stenosis becomes more than 90%, the risk becomes 16%. This is important because these things are going to give us guidelines when to intervene. So how much is the risk? Because coronary artery disease, we'll see carotid artery disease per se is not a risk factor for patients undergoing coronary artery bypass grafting. So there are limited indications. So we must know how likely that patient is likely to have stroke. So these things are going to give us the guideline. So if the lesion is less than 50%, chances of stroke is 6%. And if lesion is more than 90%, chances of stroke are 16%. Same way, if the disease is unilateral, the risk of risk of that patient getting stroke is 3% after coronary artery bypass grafting. When it is bilateral, it becomes 15%. But if occlusion is present, one side of the artery is occluded, or other side, then this becomes almost 3 times. So that gives one indication that a patient has a significant stenosis on one side and occlusion on the other side. That patient is at higher risk for getting stroke. That is why that patient needs some intervention compared to the other one. So what are the risk factors for strokes after CBG? So we can see that carotid disease does not get mentioned anywhere. A person who is getting 0.7 to 5% stroke risk for CABG, the risk factors are mural thrombus, atheromatous plaque in the ascending aorta, because we are going to manipulate the aorta, we can have a microembolism, air embolism, a person who had a previous stroke, if we have the procedure lasting for longer time, cardiopulmonary bypass time is long, so we have more chances of emboli or platelet aggregates. Those patients who have used, for whom we have to use intra-aortic balloon pump, when we have used membrane oxygenator. So we can see that carotid artery disease is per se not an independent risk factor for patients who are undergoing coronary artery bypass grafting. So that is why the indications for doing a concomitant procedure are very limited. So how does a patient with carotid disease get a stroke, and why it is not a risk factor for people who are undergoing coronary artery bypass grafting? So most common cause is that a plaque gets embolized from the carotid artery and goes to the brain. That is the most common cause. Second cause is global cerebral hyperperfusion. It is a rare event because we have extensive collateral supply in the blood in the cerebral vessels. So most of the time other vessels take care. So this is a rare cause. And then third cause is propagation of thrombus. If we have a clot in the internal carotid artery and it propagates beyond. So this clot also to be to give global symptoms or extensive symptoms, it has to cross up beyond the ophthalmic artery. If it does not cross beyond the ophthalmic artery, it will remain silent. So even a big clot is not enough. So most common cause of stroke occurring in patients with carotid disease is plaque from that carotid artery going into the brain. And in common sites of inclusion are most commonly it is a bifurcation of common carotid artery where the thing gets blocked, or in the proximal internal carotid artery, or origin of the common carotid artery. This common carotid artery is more commonly involved on the left side. Intracranial stenosis is very rare. Common sites of occlusion, that means intracranial portion of the internal carotid artery, it is very rarely affected by the atherosclerotic process. So what are the additional factors in patients who are undergoing coronary artery bypass grafting, which are going to cause that stroke? So here we are going to manipulate the aorta. So that is additional factor, additional feature. Platelet aggregates are forming during the bypass. So thrombotic phenomena is happening. We might have a hypercoagulability during the coronary artery bypass, cardiopulmonary bypass, and post-operatively atrial fibrillation and hemodynamic instability that may give rise to some thrombus, clot passing into the brain. And very rarely we have ischemia, which is causing the stroke. So we can see that mechanism of stroke in patients who have a carotid artery disease is different from what is the mechanism of stroke occurring in coronary artery bypass grafting. So we found that almost 86% of post-CABG stroke are not attributed to carotid artery disease. So when a patient is undergoing coronary artery bypass grafting, the causes of stroke are different. They are mostly coming from the aortic manipulation. They are coming from the aggregation of platelets, and they are coming rarely from the ischemia occurring due to hyperperfusion. So most of the patients who have a stroke after coronary artery bypass grafting, they are not caused by the carotid disease. They are basically caused by the fault lies in the aorta. That is why we are going to see that places where we do a concomitant pressure, the procedure incidents are the very low. So except for those patients who have bilateral stenosis or one-sided occlusion, we have seen that when there is a one-sided occlusion, the risk of stroke becomes. So these are the only people with coronary artery disease where a presence of carotid disease is going to multiply the risk, which is occurring independently in the patients with coronary artery bypass grafting. And because we are doing the coronary artery bypass grafting on pump, that time cerebral vascular resistance is decreased. So that is why ischemia is unlikely to occur. We are doing the procedure under hypothermia. So if there is little decrease in the blood supply, that is taken care by the decrease in brain metabolism. And we always there is always some hemodilation on pump, so that also counteracts the platelet aggregates and emboli formation. And whatever the cerebral autoregulation of blood flow occurs, that is related to mean arterial flow, not mean arterial pressure, not related to the flow. So even if we are doing the procedure at low flow rates, it is not the flow rate which is going to affect the brain metabolism or going to cause problems with leading to stroke. It is the mean arterial pressure. So that is why when we are doing a coronary artery bypass grafting on pump and we have a patient who has a significant carotid occlusion, we have to keep the pump pressure little higher. The pressure head should be little higher so that this person does not have any problems, because increasing the flow is not going to help. increasing the pump head pressure is going to help that trend. So only one risk factor is history of prior stroke or TIA, which is a big risk factor in patients with coronary artery bypass grafting. So we will see later that if a patient is undergoing coronary artery bypass grafting and there is a corrective lesion, only one class 1 indication for that patient to undergo concomitant procedure is presence of stroke or TIA. Other are all class 2 or class 2B indications, that is bilateral stenosis or unilateral occlusion. We'll see that later. So that is what we have limited indication for combined procedure. So whenever we have a patient with CABG, or suppose it's a patient with independent history of stroke or TIA, and he has come for evaluation of his carotid disease. Either way, both ways, we are supposed to see these histories because atherosclerosis is a generalized phenomena. It affects whole of the arterial system. So if a patient has come for CABG, in that patient also, we need to screen whole of the vascular system. And if a patient has come with stroke or TIA, and now we are evaluating that patient for isolated carotid artery disease. In both the cases, clinical history, all the things we are not supposed to ask. So these are the risk factors which we are supposed to ask: hypertension, diabetes, dyslipidemia, smoking, chronic kidney disease, sedentary life, diabetes, prior cardiovascularization, and important thing is radiation therapy. So radiation therapy is an independent risk factor for carotid artery occlusion. Then we have to ask whether patient has a transient ischemic attack or not, because transient ischemic attack is a harbinger of future stroke. Then we have to look for other vascular systems, whether other vascular systems are involved. So whether patient has any arm pain, any symptoms of angina or dyspnea, any intermittent claudication, any postprandial abdominal pain, which is abdominal angina. And very important is to ask the history of erectile dysfunction, because erectile dysfunction is sometimes first sign of generalized atherosclerosis. It is a marker of both cerebral vascular disease and cardiovascular disease. Then one important thing here is that when we have a family history of first degree relative having a premature death due to cerebrovascular disease, males the age is 55 years, and for females the age is 65 years. So any family member has fatal cerebrovascular disease or cardiovascular disease before the age of 55 in males and age of 65. So those are significant history which will tell us that there are chances that this patient might have a significant disease in carotids as well as coronaries. Some lab tests, so routine lab tests, we have to rule out diabetes, we have to fasting lipid profile, we have to do serum creatine and creatine test, renal function test, urine analysis, blood count, and uric acid. These are the basic routine tests we do in all the patients. Selectively, we have to do HbA1c or glucose tolerance test, lipoprotein A if there is a history of premature cerebrovascular death in the family, and if the dipstick test is positive, we have to. These are from the guidelines. These whatever we are speaking today is from ESC guidelines 2017 for peripheral artery disease, and some of them are taken for ACC AHA guideline or 2011. So what are the imaging studies we are supposed to required to do? So duplex ultrasound, CT angiogram, magnetic resonance angiogram. Conventional angiogram is by and large obsolete now. Transcranial Dopplers, mostly we do intraoperatively. All the patients who have come to us with symptoms of carotid artery disease or symptoms of stroke or TIA, it is a class 1 recommendation of ESC 2017 that all the patients' echocardiogram should be done. We must rule out the cardioembolic causes of the stroke also, and that is required. And this is a class 2 recommendation to do a Holter monitoring, but atrial fibrillation also might be one of the causes of cardioembolic stroke. So these are the imaging studies which we are supposed to do. We'll see them pros and cons of all of them one by one. So Doppler ultrasound is color Doppler in. So this is the first line. This is the recommendation that it is first line investigation for patients who have suspected disease. So as a first line investigation we have to do. Then which are the patients who, when they are going to when they are undergoing coronary artery bypass grafting, Doppler should be done. So those patients who have had a stroke within last 6 months or TIA within last 6 months, this is a class 1 recommendation that all those patients must be subjected to carotid duplex before undertaking the coronary artery bypass grafting. Then if they do not have any symptoms. So which are the asymptomatic patients of coronary artery bypass grafting, where we must do screening. So that is age more than 70 years, patients who have multivessel coronary artery disease, people who have concomitant lower extremities arterial disease, or people who have carotid bruit. So these patients, even if they do not have any symptoms of TIA or stroke or any central nervous system symptoms, even then we have to screen those patients for coronary artery for presence of carotid disease. But any patients who are undergoing urgent CBG or post acute coronary syndrome, if they are undergoing any CBG, for them routine screening is not required. That is class 3 recommendation. So it is not required. So just to summarize, when we have to screen an asymptomatic coronary artery bypass grafting patient with duplex ultrasound of the neck. Asymptomatic means patient does not have an TIA or stroke within past 6 months. Whatever our guidelines are telling. So symptoms means any history of TIA or stroke or a hemispheric stroke or amaurosis fugaz within the last 6 months. So I'm sorry, that slide is missing. So that is the symptom. That is the definition of symptom. If a patient has had a stroke or a amaurosis fugaz or a hemispheric stroke or a TIA in the last 6 months, that patient is called a symptomatic patient. So even if these things are not there and patient has come to me with a triple vessel disease and the cardiologist has referred to me that this patient requires 3 grafts or 4 grafts, I want you to do an off-pump coronary artery bypass grafting. I will screen him whether he has a carotid disease or not. So if he is more than 70 years of age, if the patient has carotid bruit, these are all class 2A recommendations. If the patient has multivessel coronary artery disease, if patient has a concomitant peripheral vascular disease of the lower limb, if a patient has a left main disease, this is not in the recommendation of ESC, but this is in the recommendation by AHA. So if that patient has a left main disease, these patients, even if they are asymptomatic, we have to do ultrasound of the neck before taking those patients for coronary artery bypass grafting. And obviously, if the patient has a history of TIA or stroke within past 6 months, that is a class 1 recommendation, that patient must be subjected to ultrasound of neck before going for the coronary artery bypass grafting. So what are the problems with doing ultrasound? This is for all patients, whether a coronary artery disease is present concomitantly or not. So what are the pitfalls? So, okay, just for revision, when to screen asymptomatic patient with the, so suppose we have an old patient, so suspected carotid artery disease, carotid bruit, any patient who has an ascending aortic aneurysm and more than 2 risk factors for atherosclerosis, this patient also should be screened. So we have a patient with ascending aortic aneurysm who is posted for Bental procedure or David procedure or whatever fancy procedure we are going to do on the aorta. If this patient has more than 2 risk factors for coronary artery disease, for atherosclerosis, this is again AHA recommendation. These patients must be screened for presence of carotid disease, even if they do not have any symptoms of stroke or TIA within past 6 months. Any patient who have peripheral artery disease, that also has to be screened. And those patients who have undergone a carotid artery stenting or carotid endarterectomy, all those patients will need annual follow-up by duplex ultrasound. So what are the problems with duplex ultrasound? So it will not be able to identify stenosis which is near the base of the skull. It will not be able to identify the stenosis which is at the level of airway. It is not able to identify the stenosis in the carotid which is at the vessel origins or at the base of aorta, origin of vessels or at the base of aorta. The big problem with duplex is that it uses the velocity, and according to the velocity, it uses the computerized algorithm and tells us how much is the stenosis. It does not measure the diameter directly. It uses the Doppler principle and finds what is the velocity. And based on the velocity, the computer uses the algorithm and gives us what is the decrease in diameter. So that is one fallacy. So that is why sometimes degree of stenosis may be increased if there is some tortuosity which is giving rise to turbulence. So wherever there is turbulence, the Doppler will read it as a stenosis. That turbulence might be because of tortuosity or some other problems also. So that's why it may overestimate the degree of stenosis. It may be difficult to find in heavily calcified carotids because our Doppler beam will not be passed. So in heavily calcified patients, the finding might be difficult. Whenever there is other side stenosis or occlusion, the suppose the patient has a stenosis or complete occlusion on the right side, obviously it will give higher velocity on the left side also. So this left side velocity, which is coming higher, will give us a false impression that even on the left side stenosis is high. So in presence of contralateral occlusion, particularly, the Doppler has to be interpreted and little carefully. Then comes CT angiogram and MRI. Then there are some other benefits and drawbacks of Doppler, which we all know that it is very easily available. Even at the midnight, we can get a Doppler and get a Doppler machine and do it. We can do it on bedside. The problem is that it is operator dependent. One person can find it differently. Those things are common, which we know for all the places. So we are not going to see those things. Then comes CT angiogram or MR angiogram. So again, it is recommended, this is class 1 recommendation, that it may be used as a first line imaging modality for patients where we are suspecting. So where the carotid disease, so we will evaluate and find how much there is stenosis. Whenever we are going to consider carotid artery stenting, in those patients, MR or CT angiogram must be done to reconfirm that whatever the findings was there on duplex is correct. And whenever carotid endarterectomy is also going to be done, we have to do either an MRA or CT angiogram or a repeat Doppler ultrasound by a expert vascular laboratory in a vascular, so that we know that what we are going to do is actually indication. So before stenting, we have to evaluate the arch and intracanal circulation. That is important. So that is why they have told these things. So when we are going to do a carotid artery stenting, we must evaluate what is the status of the arch and what is the status of intracanal circulation. So that, because that is important in patients who are going to go under stenting. And before surgery, we must validate that whatever finding is there on Doppler ultrasound is right. So these are the two reasons. That is why before doing either stenting or the endarterectomy, we must subject the patient either to the CT angiogram or MR angiogram. But there are some problems with CT and MR angiogram also. So CT angiogram differentiate between ischemic. So what are the benefit? To CT angiogram will be able to differentiate whether it's an ischemic stroke or hemorrhagic stroke. That is very easily done. Or then MRI is more sensitive to detecting brain ischemia, especially in early post-op period, when the symptoms, the signs have not become very evident on the CT angiogram. But whenever there is severe calcification, CT angiogram will overestimate the severity. So whenever we have a heavy calcified carotid or heavy calcified vessels, the CT angiogram may give us a false impression that this is a severe lesion when it is not. The second thing is MR angiogram will not be able to visualize vascular calcification. And this, knowing whether vessels are calcified or not, is very important for patients who are where we are planning a carotid artery stenting. So this gives an indication that if we are planning a stenting, we will prefer CT angio more than MRI, because MR angio is not going to see. That is actually contradictory, because calcification will make stenosis look more severe on CT angiogram and MR. So that is why we have always done a duplet and CT angio and or duplet and MR angio, so that two things will give us a better idea than one misleading to us. So whenever there are high grade stenosis, MR angio will find a flow wide. And very high grade stenosis, sometimes even if the vessel is patent, it will appear as if it is occluded with MR angiogram. So this gives us the reason that if we find a occluded vessel of MR angiogram, that patient is an indication for conventional carotid angiogram, 4-vessel angiogram, because we must know whether a vessel is occluded or not. Because if a vessel is occluded, that is a contraindication for any intervention on that vessel. So in very high grade stenosis, suppose a patient has 95 or 98, 99% stenosis in the carotid, the MRI will pick up that fall in signal as a flow wide and report it as if that vessel is occluded. So whenever one MR angiogram or CT angiogram has reported that vessel is occluded, that thing must be confirmed with a with a conventional angiogram. Sometimes turbulence in the vessel may make the vessel appear narrower than actual. So MR angiogram is not reliable to accurately measure the residual lumen of an artery, because the turbulence in the vessel will make it appear smaller. So these are the problems with CT angiogram or MR angiogram, but by and large, most of the intervention, they are done. And the reason we do these things is that they can image whole of the arch and intracranial. These things we cannot image with duplex ultrasound. So that is why before doing any intervention, after a duplex ultrasound, we must do either a CT angiogram or MR angiogram. Conventional angiogram is actually the gold standard imaging investigation, but it is it has inherent 1% risk of stroke associated with it, and it is rarely required for diagnosis. So just for diagnosis purpose, the conventional angiogram is not done. It is required for directing carotid artery stenting. So whenever we are planning a patient for carotid artery stenting, a conventional angiogram will be required, but it is not required for carotid endarterectomy. And one standard 4-vessel cerebral angiogram with 3 steps will do injection in the brachiocephalic trunk, intraarterial injection. Then we do selective carotid cannulation injection and see the carotids, and then we inject in the subclavian vessel to look for the bacillar symptoms. So that will give us all the 4 vessels and all the 4 intracranial vessels. So for catheter-based angiogram, it's reasonable when non-invasive imaging is insufficient. So whenever ultrasound or CT angiogram or MR angiogram are giving conflicting results, one of the investigation is telling vessel is occluded, other one is telling there's 98% stenosis, or we have any doubt. So in those patients, we have to do a conversion angiogram. Whenever we detect an occlusion on ultrasound or CT angio or MR angio, that must be confirmed by doing a conversion angiogram, because occlusion is a contraindication for surgery on that side, and it makes the other side lesion a better indication for surgery. So if we have one side occluded, one side high-grade stenosis, that high-grade stenosis gets more weightage for intervention, and the one which is occluded should not be operated. So that is why, and whenever we have some problem with dye or anything, so we may consider conventional angiogram, it will take less dye. So how to choose an investigation? So duplex is done for initial imaging and annual follow-up. CT angiogram is done whenever carotid occlusion is suspected on CT on ultrasound. We'll do a CT angiogram, but then again, if this also gives us occlusion, we'll do an MR angiogram. Whenever we have calcified carotids, the calcification, when we want to know whether calcification is present or not, in those patients, we'll do a CT angiogram, because MR will not pick up the calcifications. All patients who have acute stroke, CT angiogram is a better investigation. It gives more subjective report results. And second thing, MR angio is not possible in that time. And those patients, obviously, where we have pacemaker or anything, CT angiogram is comparatively better. When to choose MR angiogram? So whenever we have stenosis lesions, occlusions. So this is mentioned because we want to say that in occluded lesions, if we have found occlusion on CT, on ultrasound or CT angiogram, that patient MR angiogram is not useful, because there it will be problem. Any patients who have renal impairment, cardiac failure, contrast allergy, those patients MR angiogram. And when we'll choose conventional angiogram, so those patients, wherever these 3 or any of the 2 are giving a conflicting or unequivocal results, whenever we have a doubt whether this side is occluded or there's a high-grade stenosis, we have to do. And whenever we want some information, additional information of intracranial disease, so in those patients, conventional angiogram may be considered. So in most of the situation, combination of duplex ultrasound with CT or MRI is sufficient to go for this thing. Then this is because different trials have used different methods of calculating the stenosis. So NACT trial, we'll see what are those trials. So they have seen whatever the remaining lumen and the smaller lumen. But ESCST trial has seen wherever the lumen was supposed to be and wherever it is now. So here in one of them, they are comparing the proximal or distal portion with the occluded portion. And here the second one, they are comparing the occluded portion with what was it or what would it have been before it got occluded or so this will see in the details when we discuss the trial. So now comes how to go about it. So first we'll see in general what are the management for patients with carotid artery disease. Then we'll see what is to be done if the person has concomitant coronary artery disease also. So medical management is applicable to all the patients. Then intervention, we have to divide whether patient is symptomatic or asymptomatic, and then whether it requires carotid endarterectomy or carotid artery stenting. So these are the things we are going to see. So this is in short. This is in short about medical management. This is basically risk factor modification. So I have just summarized it. So smoking cessation is recommended for all patients. This is class 1 recommendation. All the patients we have to attain strict glycemic control. This is also class 1A recommendation. But it is not proven. None of the trials have so far proven that HbA1c, keeping the HbA1c less than 7 is going to prevent. So this comes in MCQ sometimes. One of the options will be it is proven. So far none of the trials have proven that if we maintain the HbA1c less than 7, it will prevent stroke or it will help us in preventing stroke. But still, strict glycemic control is class 1 indication because it is higher sugar levels or poor control is associated with a lot of problems in preoperative and postoperative periods. All the patients' hypertension must be controlled. It is class 1 recommendation, and they have class 2 recommendation that angiotensin converting enzymes inhibitors or ARB should be given in preference to other antihypertensive drugs in these patients. And we have to get, this is also class 1 recommendation that in those patients who have a carotid, significant carotid disease, significant peripheral artery disease, this is in general for all the peripheral artery disease, a target blood pressure should be kept less than 140 by 190 millicurie. Then statins are recommended to all patients to decrease the LDL cholesterol. So this is in common with all peripheral artery diseases that LDL cholesterol has to be decreased. The target cholesterol level is to be less than 70 milligram per deciliter, or at least the 50% reduction in LDL cholesterol if the baseline value is between 70 to 135. So that is the target level, and it has been proven that statins decrease the risk of stroke, particularly in those patients who have coronary artery disease. So control of sugars may not decrease the risk of a stroke, but controlling the cholesterols will definitely decrease the risk of stroke. Then if statins are not sufficient to control the lipids, then we have to add additional disease, or if they are not tolerated, then we have to take like bile acid sequestrants and nicotinic acid. All those things we have to add if the statins are not sufficient. We have to increase the physical activity. It is recommended to decrease the weight. These are all class 1 recommendations. But again, this is not proven that weight loss decreases the risk of a stroke. So this is again in MCQ. So only reduction of cholesterol has been proven to cause reduction in stroke risk in randomized controlled trials. But weight loss and weight loss and this thing are not proven. Then nutritional improvement is recommended, but still routine supplementation with a single vitamin combination is not recommended. And there are some recommendations from different associations, not from ESC, that sleep apnea should be aggressively treated. If sleep apnea is managed very well, those patients have a decreased risk of stroke, but this is not in the ESC guideline. Antiplatelet therapy has to be given to all the patients who have a stroke. So this is important. So this we have to see in detail. That is why I have mentioned it at the last. This is the first thing we do actually. So how the antiplatelet therapy is given to those patients who have carotid artery stenosis. So again, any patient who has a stenosis detected on ultrasound, he must be given antiplatelet drugs. But again, single antiplatelet therapy has not been proved in an randomized controlled trial that it decreases the risk of a stroke in a patient who has isolated carotid disease. This is important. So a patient who has isolated carotid artery stenosis and has no symptoms, none of the trials have proved that this patient giving ecosprin is going, or clopidogrel is going to decrease the risk of a stroke. That is why this is a class 2A recommendation. This is not a class 1A recommendation. That is why it is a class 2 recommendation. But in those patients who have undergone carotid surgery for symptomatic disease, once they have become symptomatic, this has been proven that this decreases the risk of stroke. And those patients who have undergone surgery, a single antiplatelet therapy is given, either aspirin or clopidogrel. This is a class 1 recommendation, at least for 1 year and then indefinitely, because it is other than decreasing the risk of stroke, it also decreases risk of cardiovascular diseases in the other systems. That is why it is single antiplatelet therapy. So practically any patient who has a stenosis in the carotid arteries, he requires a single antiplatelet drugs. Only thing is it is class 2 recommendation in asymptomatic patient and class 1 recommendation in symptomatic patients or those who have undergone surgery. Any patient who has undergone carotid artery stenting, that patient will require dual antiplatelet therapy for 1 month. That is a class 1 recommendation, and single antiplatelet drug for at least 1 year. That is also a class 1 recommendation, but practically it is given indefinitely, and long-term testing also is class 1 recommendation. So asymptomatic patient with carotid artery stenosis more than 50%, a role of single antiplatelet drug is not proven in decreasing stroke risk, but they have a 2 times increase of MI, which can be prevented by giving antiplatelets. So that is why these patients should go to get lifelong low dose aspirin to decrease the risk of other cardiovascular diseases. And this is class 2A recommendation. Clopidogrel may be given if the patient is allergic or intolerant to aspirin. Any patient who are symptomatic and where we have not done any intervention, we are just monitoring those patients or serial ultrasound, that patient also dual antiplatelet therapy may be considered if they have a minor stroke or ischemic event. So if they have this thing, that may be considered. This is not class 1 recommendation, but class 2 recommendation. And it should be started within 24 hours, continued for 1 month. So immediately after a stroke, dual antiplatelet therapy is given. It should be started within 24 hours and it should be continued for 1 month. Now, if this patient is not undergoing any intervention further, then after 1 month, he will again be put on single antiplatelet drugs. But if the patient has undergone carotid endarterectomy, lifelong low dose aspirin therapy is given. Clopidogrel may be used as an alternative. And any patient who has undergone carotid artery stenting, he will receive dual antiplatelet drugs for 1 month. Prolonged beyond 1 month in patients with recent MI or low bleeding risk. So this is again, this comes from our coronary artery bypass guideline. If this patient has a recent acute coronary syndrome, then the dual antiplatelet therapy, the guiding thing is now acute coronary syndrome, not the carotid stenting. So carotid stenting per se requires a dual antiplatelet drugs for only 1 month. But if the same patient has had an acute coronary syndrome or MI recently, then whatever the indication of that MI or recent acute coronary syndrome is telling, that much duration dual antiplatelet drugs has to be given. Otherwise, that patient will receive lifelong low dose aspirin, 75 to 100 milligram per day. I hope that is clear. So now comes what intervention. This is the medical management and antithrombotic management, antiplatelet management. Now comes what are the interventions which are required in carotid artery stenosis. And here we will discuss both the patients who have isolated coronary disease and as well as coronary as well carotid both together. So for whom it is required, when it is required, how we are supposed to do, and what else we are supposed to know. So first we'll say for whom we are required to intervene, which are the patients who cannot be managed on medical management alone. So all the guidelines have come from 2 trials which are done in symptomatic patients and 2 trials which are done in asymptomatic patients. And these are commonly asked in multiple choice questions, and these come very frequently in our Viva. So that is why first we have seen the evidence, whatever the trials are telling, then we'll see the guidelines, and then we'll see the algorithm. So there are some trials which have studied carotid endarterectomy with medical management in symptomatic patients. That is a North American study on carotid endarterectomy trial, ESCT trial, European carotid surgery trial. So these are the 2 trials which have studied carotid endarterectomy versus medical management in symptomatic patients. In asymptomatic patients, there are three trials: asymptomatic coronary artery surgery trial, asymptomatic coronary surgery trial 1. This is first, and there's a veteran affairs cooperative study group which have studied the carotid endarterectomy and medical management in those patients who do not have symptoms of carotid disease. Then we have trials which have compared the carotid endarterectomy to with carotid stenting. That is also in symptomatic patient. There are multiple trials. These are not established now. These are all in evaluation phase. And carotid artery stenting is so far not an established treatment for. Now it is being done with increasing frequency nowadays in all the places. People are doing it left, right, and center, but it has not been established to be non-inferior to surgery. So there are some trials which have been done and which are going on: Sapphire, Space, EVA 3. These names we'll find. Some MCQs might come from this. That is not very important. So we have just for completion sake, I have mentioned. Then there are some there is only one trial in asymptomatic patients, that is asymptomatic coronary surgery trial 2, which is comparing coronary endarterectomy with coronary artery surgery and stenting in asymptomatic patient. There are two more trials which are read because we are not supposed to know much. These are ongoing, but what is important about them are that they're comparing best medical management with coronary artery, carotid artery stenting and endarterectomy, because all the trials which have given us the guidelines, the NASCT, ESCT trial, these trials were done in 90s, and since then a lot of water has flown under the river, and Ganga has got a lot polluted. So, but we have got better medications. We have got many more medication. So, are those better medications better than surgery or not? If those medications are proven to be better than surgery, then surgery will be thrown out of the window. So, these two trials are addressing, but we are not supposed to know anything more right now. So this is first trial, European carotid surgery trial. I have tried to summarize the thing. So this trial took patients with recent non-disabling carotid artery ischemic event and more than 80% ipsilateral stenosis. That was found on contrast and angiography. So these patients had more than 80% stenosis and non-disabling carotid artery ischemic. That means either TIA or non-disabling stroke. All those patients who had disabling stroke, they are not studied. They were randomized to receive either best medical management or carotid endarterectomy, and they found that risk of major stroke or death complicating surgery did not vary substantially with severity of stenosis. So here they did not find any change, any difference with stenosis. And risk of major ischemic stroke ipsilateral to unoperated symptomatic carotid artery increased with severity of stenosis above 70 to 80%. So total stroke or death risk did not increase, but major ischemic stroke increase whenever lesion was more than 70 to 80% stenosis. So if stenosis is more than 70 to 80%, that patient is more likely to have a ischemic stroke. Okay. When the stenosis was more than 80%, there was 11% absolute risk reduction in risk of major stroke with surgery. So this trial showed that in these patients, despite them being symptoms, if they have undergone carotid endarterectomy, there's 11% absolute risk reduction in risk of major stroke. If the diameter is stenosis was more than 80% in diameter. They said that age and sex modified the simple rule based on stenosis severity. So age and sex has to be considered before we are taking this patient for carotid endarterectomy. So their conclusion was carotid endarterectomy is indicated for most of the patients with recent non-disabling carotid ischemic event when the symptomatic stenosis is more than 80%. So from here, this cutoff has come as 80%. If the patient has symptoms and stenosis is more than 80%, that patient will have 11% absolute risk reduction with surgery if the surgery is added to best medical management. So this is one trial which gave us something, and this comes in multiple trials. Second one is North American symptomatic carotid endarterectomy trial. So here also symptomatic patients were studied, and they were randomized between the best medical management and carotid endarterectomy. So these patients who had hemispheric or retinal transient ischemic attack, non-disabling stroke within 120 days, and ipsilateral carotid stenosis. They classified them into three categories, whether 30 to 69% stenosis and those who had 70 to 99% stenosis. The patient who has 100% stenosis or occlusion is not a candidate for endarterectomy. So that is why they are not in this trial. They were randomized to receive best medical management or carotid endarterectomy in addition to best medical management. And then they found that for high grade stenosis, they did not find any benefit with carotid endarterectomy in patients who had 70 to 99% stenosis. But all those patients who had 70 to 99% stenosis, there was 17% absolute rate reduction in ipsilateral stroke with surgery at 2 years, and 10% absolute rate reduction in fatal or major stroke with surgery. So any stroke was 17% less, and fatal stroke was 10% less if the patient has undergone surgery within 10 years. And it was still found beneficial when all deaths and strokes were included, though it was not significant. So carotid endarterectomy was then proven that it is beneficial in those patients who have symptoms and who have more than 70 to 99% stenosis. Then they had their 8 years follow-up also later. Here also they found that overall rate of perioperative stroke was 6.5%. Why this 6.5% is important? That intervention, when we are doing intervention on a symptomatic patient, we will see that the cutoff value is given for symptomatic and asymptomatic patient, that if a documented risk of procedure is more than 3% or 6%, that patient will not be operated. We'll see that later. So rate of permanently disabling stroke was, that was only 2%. And patient who had more than 70% stenosis, they had durable benefit at 8 years also. So that then they have proved that it is beneficial in long term also, not only 2 years, 8 years results are also back. And 8 years risk of disabling stimulated stroke are only 5.7%. So they've identified 5 baseline variables which were predictive of increased surgical risk. So wherever risk of surgery is more, so left-sided procedures, if the contralateral carotid is occluded, if there is ischemic lesion on the CT scan, or if there is irregular or ulcerated ipsilateral plaque, or if the hemispheric, or if there is hemispheric transient ischemic attack compared to right canal. So these were the patients who had high risk of stroke also, and these are the patients who have high risk of surgery also. So these are the 5 baseline variables which were predictive. So this trial gave us that. And they established the carotid endarterectomy is highly beneficial to patients with recent hemispheric and retinal transient ischemic attacks or non-disabling strokes. Okay, if they have high-grade stenosis, that was the conclusion. And they also found that if patient stenosis is 0 to 49%, there is no benefit. In those patients who have 50 to 69% stenosis, there is absolute reduction of 7.8%. And those patients who have 70 to 99% stenosis, the reduction is almost double, 15%. So that is why all the recommendations where we are finding recommendations for doing surgery are speaking of lesions more than 70 to 99%. Then there was Veterans Affairs. So this was a study in asymptomatic patients. This patient only men were included, or asymptomatic patient, and wherever carotid stenosis of more than 50% was found. So they found that risk of stroke was lower in patients who undergone surgery, and stroke and death combined at 30% also. But if we combine the stroke and death, did not find any significant difference. So their conclusion was it reduced the overall incidence of ipsilateral neurologic events in a selected group of male patients, but did not find any significant influence of carotid endarterectomy on combined incidence of stroke or death. So here, this trial has given us the thing that if a patient is asymptomatic and stenosis is less, that patient will not benefit with a stroke. That patient will not benefit with surgery with respect to stroke. Then this is the trial which is mentioned in all the places, and MCQs are asked from this one, asymptomatic carotid artery stenosis trial. So here they have, now this is 60%. That one was studying 50%. This one 60% or greater stenosis, asymptomatic patient, randomized to best medical management versus carotid endarterectomy and best medical management. So they found that aggregate risk for ipsilateral stroke or any perioperative stroke or death was lower for patients who were treated surgically, and it was associated with a 50%, more than half of the patient benefited. So that ACAS trial is the trial which has given us a foundation for treating asymptomatic patients, because they have shown aggregate risk reduction of 53%. More than half of the patients are benefited if they are taking aggregate of ipsilateral stroke or any stroke, perioperative stroke or death. So they concluded that patient with asymptomatic carotid stenosis of more than 60%, and whose general health makes them good candidate for elective surgery. So all these things will come in guideline. Will have a reduced 5-year risk of epileptic stroke if carotid endarterectomy can be performed with less than 3% perioperative morbidity and mortality. So there we have seen 6% and this is 3%. So in the symptomatic one, we have seen that 6% was the cutoff of risk and here is the 6. So that is why in a patient who is asymptomatic, if we are able to perform a carotid endarterectomy with predicted risk of stroke, perioperative stroke less than 3%, then only that patient is indicated. So suppose any, that is why carotid artery stenting is not an established procedure, because all the reported series of carotid artery stenting report a risk of stroke after stenting almost 3 to 4%. So that is not acceptable. So this is important. So ACAS trial has given us this thing that patients should be offered surgery only if we can perform the surgery with risk of perioperative morbidity or mortality less than 3%. If my center is in my center, result of carotid endarterectomy is showing more than 5% or 6% perioperative morbidity, my center should not be performing carotid endarterectomy on patients who are asymptomatic, because that is unacceptable. The risk reduction is not going to be beneficial. Then there's ACST1 trial that is uh, 10 years. 10 years. This trial has shown that at 10 years also results are good. So here what was done? So they have considered any stroke or perioperative death and any non-operative stroke. Non-operative stroke means patient has a stroke on the other side. So that becomes a non-perioperative stroke. So combining perioperative death, there was net gain of 4.1% at 5 years and 4.6% at 10 years. And if we are considering only non-perioperative, still there was gain of 5.6%. These figures we don't need to remember. Just because I'm presenting to a big group of people, I'm writing all the figures. So what this trial has said, that net benefit was significant both even on those patients who were not taking lipid lowering agents. It was significant both for men and women because our VA study had taken only men. So this trial showed that net benefit was there for men and women also. And it was significant for those who were less than 75 years of age, but not for who were old, younger. So what they have said, not for more than 75. So this is this typing mistake. So their conclusion was successful carotid endarterectomy for asymptomatic patients younger than 75 years of age reduces the 10-year stroke risk. Half this reduction is in disabling stroke or fatal stroke. So this ACAS trial is again basis on which we are going to operate on the asymptomatic patients. That is why this trial is important. That is why this is asked. So this has said if the patient is more than 75 years of age, those patients are not going to benefit. So less than 75 years, asymptomatic and stenosis more than 60%, that patient becomes an indication for surgery. I'm sorry, this is a lot of facts. And since I have read it, so it seems very easy for me. And I have prepared the slides, so it appears as if it is easy. But then there is not a lot of concept in these trials. The concept will come later when we discuss the Viva questions. So who are the patients who are more likely to develop a stroke? If this patient is asymptomatic and the patient is telling that, no, I don't want to undergo this procedure. I don't have any symptoms. Why should I undergo the procedure? So if that patient has some features, we'll have to ask them. So if the patient has had a history of contralateral stroke or TIA, obviously, if he has a stroke on this side, other side also, we have to treat. If the CT scan on MRI is showing that there's a small infarct, lacunar infarct or some infarct on that patient on the same side on which he has a stenosis. So even in absence of symptom of TIA or stroke, that patient will require. On serial ultrasound monitoring, if we find that more than 20% increase is there in the stenosis, or we find in transcranial Doppler that there is a spontaneous embolization occurring from that plaque. If the cerebral vascular reserve is low, any patient who has large plaque or who has soft plaque, equilucent plaques, we have soft plaque, or any patient who has a hypogenic. So these are the features of ultrasound. If the patient has these patients, or MRI is showing that there is intraplaque hemorrhage, or there is a necrotic core which is rich in lipid, it is likely to burst and throw an embolus. So if that patient is arguing, no, I don't have any symptoms. I don't want to undergo carotid endarterectomy. Why should I subject myself to this procedure? So we have these warning signs. We have to tell him that, see, you have these warning signs, and that is why you require surgery. So now we come to guidelines. What are the guidelines? So any patients who are asymptomatic and who has 60 to 99% stenosis, carotid endarterectomy is class 2B recommendation. Okay, okay. But it should be, we should be able to perform this if our documented perioperative stroke or death rate is less than 3%. That is what ACAS trial had told us. And life expectancy is more than 5 years. We'll see. I have simplified these things. I'm just going to read these things. And any average surgical risk patient who has 60 to 69% carotid artery stenting may be an alternative. That is class 2B recommendation. So asymptomatic patient, 60 to 99% stenosis, carotid endarterectomy is preferred over the carotid artery surgery or stenting. So that is why, and both are class 2B recommendation, class 2A and 2B recommendations. Any patients who is asymptomatic and high surgical risk. High risk for carotid endarterectomy means that patient carotid artery stenting should be considered. So any patient who is asymptomatic has 60 to 99% stenosis, but he is high surgical risk patient. That patient will require stenting, provided he has life expectancy of more than 5 years and stroke or death rate at our center is less than 3%. What are the recommendations for symptomatic patients? So symptomatic patients, average risk, carotid endarterectomy is the class 1 recommendations. So here the percentage is 70 to 99%. For asymptomatic, our this thing was 60 to 99%. Here for symptomatic patient, the cutoff is 70 to 99%. And here our procedure we should be able to perform our procedure with less than 6% peri-procedure death or stroke rate. If my center performs carotid endarterectomy with annual rate of more than 6%, then I should not be performing this. And in those patients, if the lesion is 50 to 69%, this is class 2A recommendation. So they are also a candidate for surgery, but this is class 2A recommendation, carotid endarterectomy. And average surgical risk patient, carotid artery stenting is a third option. So patients who have average surgical risk, they are to be operated and carotid endarterectomy is done. This is either class 1 or class 2A recommendation depending on severity. For them, carotid artery stenting is an alternative. This is not the first choice. First choice is always carotid endarterectomy. And those patients who are high risk for carotid endarterectomy, in those patients, we should consider carotid artery stenting first. That those are the patients who will require. And it should not be done in patients who have less than 50%. Any symptomatic patient, if we have less than 50% stenosis on the same side, revascularization is not indicated. Here by revascularization, we mean either carotid endarterectomy or carotid artery stenting. Both are not recommended. Now, what are the recommendations of patients who are undergoing coronary artery bypass grafting? We'll see the recommendation, then we'll see the algorithm flow charts. So now we have just seen when are we going to screen. So a patient has come to me, been referred to me with triple vessel disease. If he has these symptoms, I will do a carotid artery Doppler, neck Doppler, and find out whether he has some problem or not. So all symptomatic carotid stenosis, carotid reduction should be considered. If 50 to 99% stenosis, this is class 2A recommendation. So any patient who is coming for coronary artery bypass grafting, if he has TIA or stroke within past 6 months, that patient will require a carotid revascularization, which may be carotid endarterectomy or carotid artery stenting. That is class 2A recommendation. So for all practical purpose, that's an indication. Now, next thing says carotid reduction with carotid endarterectomy should be considered as first choice. So the guidelines have told us two things. Any patient has been referred to us for coronary artery bypass grafting, and on history we find that he had a TIA within 6 months or a stroke within past 6 months or a year. So that patient we have evaluated and find out how much is the stenosis. If that patient has more than 50% stenosis, that patient requires carotid endarterectomy also. Which one will be done first or later, that we see later. That patient will require some revascularization, and that revascularization, carotid endarterectomy is the first choice. The carotid artery stenting is the second choice. Okay. And if that patient, even if he has symptoms, if he has less than 50% stenosis, revascularization is not required. So a patient has come to me with coronary artery bypass, for coronary artery bypass grafting. We take a history and we find that patient had a TIA, and we do a Doppler and we find that stenosis is less than 50%. So that means the stroke in that patient was not caused by the carotid stenosis. It might have been due to atrial fibrillation. It might have been due to fibromuscular dysplasia. It might have been due to some other reason. So that is why if the stenosis is less than 50%, despite being symptom, that patient does not require a procedure on his carotid. Now comes the asymptomatic stenosis. So we had a 65 years or 65 years old male patient who had come to us for coronary artery bypass grafting. We reviewed the coronary angiogram and we found he has a left main disease. So moment we find that he has a left main disease, so we asked whether did you have a stroke or TIA or any neurological symptom within past 6 months. He said, no doctor, I did not have it. But still, since he has a left main disease, that patient requires the carotid to be evaluated. And now we have evaluated the carotid and then we have found that there is some stenosis. So whether that stenosis requires a treatment or not. So this is class 2B recommendation. If the patient has bilateral 70 to 99%. So we had seen that presence of carotid disease in a patient who is undergoing coronary artery bypass grafting per se is not a risk factor for a stroke. That is why the recommendations are very stringent. So only if patient has bilateral 70 to 99% stenosis or stenosis on one side, which is 70 to 99% and other side is occluded, that patients will require a carotid endarterectomy, and that too is class 2B recommended. So it may be considered. The thing is class 1 is recommended, class 2 is should be done, class 2B is may be considered. So in those patients, carotid endarterectomy or carotid stenting may be considered. Any patients where there are signs and symptoms which tell us that this patient is at increased risk of ipsilateral stroke, like if the patient's plaque is soft, if the patient has some signs of ischemia on the cerebral imaging, or that patient has intraplaque hemorrhage, that patient is more likely to develop a stroke. So in those patients, to reduce the risk of stroke, we may consider. So then again, class 2B in that patient also, it may be considered to do a carotid procedure. But routine prophylactic respiration is not required. So here also, routinely it is not to be done. It is to be done only if it is bilateral, or there is a contralateral occlusion, or there are compelling reasons which are telling us that this patient is more likely to develop a stroke after surgery. So in those patients, we will do the procedure. So this is the algorithm for patients who are undergoing coronary artery bypass grafting, and I have tried to simplify this. We'll see that. So we have asymptomatic patient, 60 to 69% stenosis, features suggestive of high stroke risk on the imaging. We have that expected survival is more than 5 years, and our center can perform the procedure with less than 3% perioperative risk of stroke or death. This includes stroke or death both. If all these things are satisfied, then we'll see how much is the surgical risk. Surgical risk may better with other comorbidities. So asymptomatic patients, if he has average surgical risk, in these patients, this is class 2A recommendation. We should consider carotid endarterectomy, and carotid artery stenting is an alternative. That is class 2B recommendation. So all these things, if any one of them is, and this patient will require receive the best medical management, that is no doubt. Any one of these is negative, that patient will receive only medical management. If the stenosis is less than 60%, patient asymptomatic, stenosis less than 60%, only best medical management. Patient asymptomatic, no features are telling that patient is very likely to have a stroke, he will receive only best medical treatment. If the patient is asymptomatic but expected survival is only less than 5 years, then also patient will not go surgery. Or if my center is performing this procedure with risk of perioperative stroke or death more than 3%, that patient also BMT, best medical management, only will be given. If everything is satisfied, then that patient, first option is endarterectomy, second option is stenting. Same patient, asymptomatic, all the things are, and this patient is high risk for surgery. So what is the thing? So if is high risk for surgery, then that patient should not be offered carotid endarterectomy. That patient should be offered carotid artery stenting, because risk, we know anything based medical management, any one of these is negative, lesion is less than 60%, or patients do not have risk factors, or survival is less than 5 years, or my perioperative stroke risk is more than 3%, that patient will receive only best medical management. So asymptomatic, in short, whatever the white charts are, asymptomatic patient, average surgical risk, carotid endarterectomy. Asymptomatic patient, high surgical risk, carotid artery stenting. Two things we have to remember. Asymptomatic patient, average surgical risk, carotid endarterectomy. Lesion percentage 60 to 90%. And asymptomatic patient, high surgical risk, carotid artery stenting. Now comes to symptomatic patients. This is all the guidelines I am just revising. If patient has 70 to 99% stenosis and less than 6% procedural risk of stroke or death, and the patient is average risk of surgical, carotid endarterectomy is the recommendation. If in this patient, 2B recommendation, carotid artery stenting may be considered as an alternative if there are other reasons too, and this patient will receive best medical management also. But if the patient is high surgical risk, best medical management is given, and carotid artery stenting is the second thing. So both the patients will receive this thing. The moment patient is high surgical risk, he will go for a stenting. The moment patient is average surgical risk, he will go for carotid endarterectomy. Now lesion is little less severe. Patient is only 50 to 69% stenosis. Average surgical risk patient, even then carotid endarterectomy is the preferred modality. High average surgical risk patient, sorry, this is high surgical risk patient, carotid endarterectomy. Uh, this is wrong actually. Okay, this is not average surgical risk. Anyways, any patient who is asymptomatic and less than 60% stenosis, only best medical management. Any patient who is asymptomatic and has occlusion, only best medical management. So occluded patient or less than 60% stenosis patient will not require any treatment. Any patient who is symptomatic and less than 50% stenosis, only best medical management. Any patient who is symptomatic or has occlusion. So occlusion, any patient wherever 100% occlusion is there, whether the patient is symptomatic or not, that is a contraindication for that patient will receive only best medical management. Any asymptomatic patient less than 60% stenosis, only best medical management. Any symptomatic patient less than 50% stenosis, only best medical management. Those patients are not candidate for surgery. Now comes for CABG. So these charts are these flow charts are all the guidance together. So any patient who has symptomatic carotid stenosis disease and stenosis is more than 50%, we should consider revascularization, and carotid endarterectomy is the first choice. More than 50% stenosis in a symptomatic patient. Symptomatic means TIA or stroke within past 6 months. That patient we should consider revascularization, and carotid endarterectomy is first choice. This is class 2A recommendation. Whenever stenosis is less than 50%, revascularization is not indicated, class 3. Now, a patient who is undergoing coronary bypass grafting, he's asymptomatic, unilateral 70 to 99% stenosis. We don't need to revascularize. So routine revascularization is not even if this is a high grade lesion, but this patient does not require routine revascularization if it is asymptomatic. But if he has bilateral high grade stenosis, or has a contralateral occlusion, or there are features which are telling that he is very likely to have a stroke. There is intraplaque hemorrhage, or soft plaque, or very large plaque, or loose plaque. So all those patients will require, we may consider revascularization. Here it is class 2B recommendation. These patients we may consider. So we can see that for patients who are undergoing coronary artery bypass grafting, if they are asymptomatic, suppose if we were to err, we would err on the side of not doing anything on the carotid. But for symptomatic patient, if we had to err, we will err on the side of doing a carotid endarterectomy if lesion is more than 50% stenosed. Just for completion's sake, if patient has vertebral artery stenosis, the cutoff here is 50%. For those patients who have more than 50% occlusion and recurrent ischemic event, there we may consider to revascularize the vertebral arteries, but it is not recommended if it is less than 50% or if it is asymptomatic. Now we have to see how. We have seen for whom we have to do, and when we have to do when also we have to see. So how means whether distinct carotid endarterectomy or stenting. So guidelines have clearly told that so far carotid endarterectomy is the preferred treatment modality in all patients who have low surgical risk, and carotid artery stenting is preferred modality in those patients who have high surgical risk. So wherever surgical risk is high, we have to see, but there are some other things also which we have to consider when we are deciding about the carotid endarterectomy or stenting. I have not gone into detail of these trials. This is from one paper in Journal of Atherosclerosis and Thrombosis 2017. So if people want, I will send this paper on the group. It has summarized all the trials. Since all these trials have not given a clear-cut outline, and since many of them are still ongoing, so we have not gone into details. Most of them are non-inferiority trial where they want to show that carotid artery stenting is not inferior to carotid endarterectomy. So in asymptomatic patients, they have SAPPHIRE, which is high risk group, CREST, ACT, and SPACE 2. And symptomatic patients, in symptomatic patient, CAVATAS, SAPPHIRE, EVA 3S, SPACE 1. I haven't found any MCQs also from this, and probably it would become too much of data. So I have skipped this. So what is the gist of all these trials and meta-analysis? So for carotid endarterectomy, generally it requires general anesthesia, though it can be done in local anesthesia, which is not required in carotid artery stenting. The risk of perioperative MI is more in patients who are undergoing endarterectomy and less in the patients who are undergoing stenting. The reverse is true for stroke. Risk of perioperative stroke is lower in patients who are undergoing carotid endarterectomy and higher in patients who are going stenting. Stenting is associated with higher risk of stroke because calcified vessels, there is chances of embolization occurring at the time of deployment. So that is why this is a class 2A recommendation from ESC to use protection devices whenever we are doing a carotid artery stenting. Cranial nerve injury is more with endarterectomy. Obviously, we are going to cut and sew there in the neck. Recovery time obviously will be longer because we are going to do procedure. Wound complication, obviously it will be more with carotid endarterectomy. But suppose it's an staged procedure. If the patient has undergone stenting, at least we'll have to wait for at least 4 weeks. If we have done a carotid artery stenting and that patient also requires coronary artery bypass grafting, we have to wait at least for 4 weeks, because for 4 weeks that patient will require dual antiplatelet drugs. Or else we'll have to take the risk of excessive bleeding and go ahead with the procedure. So that is one drawback with carotid artery stenting. But carotid artery stenting is beneficial also in some places. So whenever we have hostile neck, if a patient has undergone previous neck radiation or radical neck dissection, so dissecting and doing a carotid endarterectomy is going to be difficult. So those patients, stenting is better. Any patient where we have recurrent stenosis, if patient has undergone carotid endarterectomy in the past and this patient now requires a repeat procedure, that patient will be better served with stenting. Whenever we have contralateral rectal nerve palsy, this patient also we should not try of doing a surgery. God forbid, if we paralyze the other nerve also, we will not be able to extubate the patient. Patient will be there on ventilator or will have to do a tracheostomy. So any patient wherever we have a contralateral rectal nerve palsy, that patient we should, and it requires revascularization, we should ask him to go for carotid artery stenting. Any patients who are surgically challenging places like very high internal carotid artery lesion, wherever patient has a very high bifurcation, or whenever patient has a lesion in the very proximal segment of the common carotid artery, these patients they will be probably better served with stenting. And wherever there are very high risk of cardiac complications, so we cannot subject those patients for surgery because chances of MI will be high. So in those patients, we have to offer them coronary artery stenting. Where they have problem, so stenting has problem wherever there is tortuous vessels, arch vessels or supraartic vessels are tortuous, stenting is difficult. Whenever we have a very long lesion, we will not be able to deploy the stent. Heavily calcified lesions, chances are that that calcium will break when we are going to deploy the stent, and then it will lead to procedure stroke. Any patient where we have a obvious thrombus or obvious filling defect, those patients should be served with surgery, not with stenting, because thrombus will break and go into the brain. String lesions or patients who have soft plaques or intraplaque hemorrhage is present, those patients should not be subjected to stenting. This is important. If any patient has very poor peripheral vessels, we will not be able to put in the guide wire and assembly thing. assembly inside. So poor femoral vessels or poor peripheral artery disease patients, they are also not suitable candidates for carotid artery stenting. Those patients who have extreme cerebral atrophy or those who are not able to receive dual antiplatelet drugs, uh, patients with active bleeding ulcers, or those patients where we cannot give dual antiplatelet therapy, those patients we should not be subjecting to carotid artery stenting. Oh, it's 11 o'clock. So this is a good paper. You can take a snapshot, and they have told to direct us whether to do stenting or endarterectomy. First thing is absolute indications for carotid artery stenting. Patient who has heart failure, ejection fraction is less than 30%. He had an MI within the last 4 months, or he requires open heart surgery within 6 weeks, or there is severe pulmonary dysfunction where contracted carotid artery is occluded, or where we have contracted laryngeal paralysis, that is reclined angina paralysis is there. Wherever we have a very high stenosis above the C2 level, or very low stenosis, which is below the clavicle, where we cannot reach with surgery. Whenever patient has undergone previous neck radiation or previous neck surgery, or a patient who has had a carotid endarterectomy before this, or a tracheostomy. These patients, they are absolute indication for doing carotid artery stenting. These patients we cannot offer carotid endarterectomy. There are some absolute indication for carotid endarterectomy. Wherever we cannot perform a conventional angiogram, we are obviously not be able to do. Some peripheral vascular disease, we are not able to have femoral access site. Whenever we have allergy to contrast or very heavily calcified lesions, they have recent circumference more than 270% lesion. So those patients, carotid endarterectomy is absolutely indicated. We cannot offer those patients sorry stenting. Then there are some equivocal things where endarterectomy is favorable. So renal failure without hemodialysis, very complicated atheroma and ascending aorta. This patient probably I will put in the category of carotid endarterectomy, not in the absolute indication, not in the patient who will go to type 3 aortic arch, string sign, ulcerated lesions. Length of the lesion is more than 30 millimeter, and wherever thrombus is present, or we have moderate calcification. These patients, so half of the patient, these will go carotid endarterectomy. Stenting can be considered in patients who have stable angina or ejection fraction is less, all those patients. One chart is missing. Acha, it will come later. It will come later. So what is the timing? When are we going to do this procedure? Now we have seen for whom and how, what, when is to be done. What is the timing? So isolated carotid stenosis, there is no confusion. Uh, Earlier there used to be that we have to wait for 14 days before we do the procedure, but now that is not there. So it is a class 1 recommendation. We should do it as soon as after the patient has had a stroke and revascularized that artery, because chances of recurrent stroke is 7% in within 2 days and 10% within 7 days. Now, patient undergoing coronary artery bypass grafting, that is the confusion. Whether we have to do CAA first, then CABG, that is called stage procedure, or we have to do the CABG first and then carotid endarterectomy, that is called reverse stage procedure, or we have to do both together. So there is a lot of confusion, and there's not no one single answer. If we are subjected to this question in the examination, we have to tread the middle path and decide as per the given patient. There's nothing one size fits all phenomena in this. This is a very busy chart. This is again taken from so they have given the risk of death, stroke, MI, and all this complexes. So they have compared carotid endarterectomy with CABG, where carotid endarterectomy done before bypass, carotid endarterectomy with CABG, where carotid done on bypass, or carotid endarterectomy with off-pump this thing, then stage CA but CABG, then reverse stage CABG, CAG, stage CA. All these things they have studied, and they have found almost the same. Pardon. So stage procedures, if we do carotid endarterectomy first, then chances of MI are more, stroke are less. If we do CABG first, then chances of stroke are more, MI is less. If we do both procedures, that's the trade-off between the two. So whenever we do endarterectomy first, chances of MI are more. Wherever do we CABG first, chances of stroke are more. in stage procedures of carotid artery stenting, still stroke risk is high because it does not give protection to uh, from the embolism. So despite use of this thing, and when we do contract stenting, the CABG first, then also stroke risk is high. So basically, if we do the procedure on carotid first, risk of cardiac complication is high. If we do procedure on the heart first, chances of stroke are high. Synchronous, when we do, this is a trade-off, but synchronous thing is not done very frequently. We'll see why. So there are some meta-analysis and reports. So this is a report of around 6,000 patients from USA. So they found there's no significant difference in mortality or neurological complication between a staged and synchronous procedure. So if we do both together, there's no significant difference in mortality and neurological difference. And staged procedure are associated with a greater risk of overall complication and higher hospital charges than synchronous. So when we do a staged procedure, this study is favoring that we should do both the things together. And additional thing, they found that if the patients are operated on pump, they are associated with higher risk of stroke. Probably this might be related that patients who are on pump, uh, there are more chances of microemboli and more chances of handling of aorta because we are doing additional cannulation and all those things. So this study favored asynchronous procedure. There's another meta-analysis of stage versus combined carotid procedure. Here also they said that both had comparable results, and two studies can be used interchangeably in clinical practice, with each having specific applications linked to specific clinical condition. So whenever we are asked such a question, whether you do a carotid endarterectomy first or a CABG first, our answer should be catered to the patient which we have been given in the exam and to the center where we are doing. My boss always did carotid endarterectomy on bypass. So after opening the chest, then he does the neck thing. So again, it is a personal choice also. Then another study, it is a Cochrane review. Here also early outcomes were, they have said early outcomes after synchronous carotid endarterectomy plus off-pump CABG are better than stage procedures if the on-pump CABG are performed. So here they have favored that off-pump CABG has better results if we do a synchronous procedure compared to on-pump one. Okay. So how the things are decided? So we have a patient with coronary disease, carotid disease, do a duplex scan. If it's negative, obviously he goes for CABG. If the duplex scan is positive, we do a CT scan on MRI, and when we find out whether lesion is there now. Now we found that there's a lesion. This patient has symptoms of carotid disease or not. If symptoms of carotid disease are present and patient has unstable angina or left main disease or poor LV function, so here we'll have to do combined procedure only. We have to do synchronous CABG and carotid artery stenting because carotid disease is also symptomatic, and heart function is also poor. So if we do a stenting or endarterectomy first, chances of MI is there, or if we do a CABG first, then chances of stroke are there. So this patient where both the things are strong indication, we have to do a combined procedure. So probably this is the only reason for doing combined procedure. If patient has symptomatic carotid disease, that means chances of stroke are high, but the patient has stable angina and good LV function. So that means chances of MI, perioperative MI is less. So in this patient, we'll do a staged carotid endarterectomy followed by CABG. That means carotid endarterectomy will be done now, and in the same admission, CABG will be done later. So this is, now the patient does not have any symptoms of carotid disease, and patient is undergoing elective coronary bypass grafting. That's unilateral stenosis. That means that's not very strong indication for doing a carotid procedure. He can either undergo CABG alone because this is unilateral stenosis, or reverse CABG and endarterectomy. CABG now and endarterectomy later if it is required. But if the patient has bilateral high-grade stenosis or contralateral occlusion, or and the patient is undergoing elective CABG, then that patient can be staged for CABG followed carotid endarterectomy followed by CABG. So basically, we have to weigh in the risk of both the things. Whichever risk is more, that risk we have to try to decrease. Now comes the discussion part. This is actually, I'm very sorry, we are stretching till 11 o'clock, but these are the things which will be asked in the Viva. What are the things which will be asked? So steps of carotid endarterectomy. For the benefit of time, I have left it. There are a lot of videos and some variations on YouTube also. If our center is not doing, we can see those videos. What are the complications? Some questions are whether you will do it on general anesthesia or local anesthesia, whether you will do it on pump or off pump, whether you will do the endarterectomy before opening the chest, or you will open the chest, put the patient on bypass and then do it, or after opening the chest before doing bypass, whether you will put or shunt or not shunt, how will you monitor the cerebral function, how will you prevent the stroke, whether you will put or patch or not, whether you will do a vein patch or vortex patch or pericardium patch, whether you will do eversion or no eversion endarterectomy, what will you do if the patient has high carotid bifurcation, and how will you follow up this patient. So these are the questions which are asked in the exam. First is complications. So complications are stroke, myocardial infarction, cerebral hyperperfusion syndrome, cranial nerve injuries, vein patch rupture, postoperative hemodynamic instability, hematoma or infection, and recurrent stenosis. So we'll see them one by one. This will go fast because not much is there. So chances of stroke are more in patients who have symptoms and other side is occluded. And on that, in this patient, we are doing a endarterectomy. So that is a single surviving vessel. We are doing something. So that patient will have chances. If the patient had a stroke earlier, that is the most strongest risk factor for having intraoperative or postoperative stroke. Patients who are hypertensive, when we use general anesthesia, chances of stroke are more because we will not be able to monitor whether shunt is required or not. And contrastingly, use of shunt intraoperatively associated with higher risk of stroke, because the very fact that we are forced to use the shunt, it means that circulation is compromised beyond repair. How does a stroke occur? So most common cause of stroke occurring after carotid endarterectomy is thrombus or thromboembolism, which presents itself in 24 hours. Sometimes it is due to ischemia that occurs during clamping if we are not observant. Sometimes it is due to intracerebral hemorrhage, which we cannot do much. Sometimes it is unrelated to our surgery that patient was destined to have. Sometimes there is some technical problem. So if we have we have left the intima in the distal thing, and or we have left the flap. If it occurs within 24 hours, chances are that it is due to thromboembolism. That patient requires immediate re-exploration. So if we find that in the operation theater itself, after coming from anesthesia, we are finding there are some stroke features, that patient we should not shift out of the operation theater. We must do a duplex scan intraoperatively there, then and there, open the wound and find what is the problem. But suppose the patient has woken up from surgery and gone to the ward, he is fine, and he develops a stroke within first 24 hours, most likely there is occlusion, there is thrombus formed at the site of carotid endarterectomy. That patient must be immediately re-explored. And this patient also, before exploration, we must do a ultrasound or a CT. If it is fastly available, we can do a CT scan. And this thing, that patient should be re-explored. One option is there to do intra-arterial thrombolysis. Sometimes it is done, but if there is a technical problem on the scanning, that patient probably should go for surgery. If it occurs after 24 hours, generally it is not because of clot. It is because of other reasons, like some flap has become bigger or some ledge has become developed. So in that patients, we have to do ultrasound, CT angio or catheter angio, and then accordingly plan. Then a complication is cerebral hyperperfusion. This is also asked in multiple choice questions. This is seen in 1 to 2% of patients who are undergoing carotid endarterectomy. It presents, the patient will have sudden hypertension and headache, and then it will be followed by focal neurological deficits or seizures or hemiparesis. So first symptom is headache, and then headache, which is associated with hypertension, and then patient will have some focal neurological deficit. So this occurs due to, it may lead to intracranial hemorrhage also, and mostly it occurs on postoperative day 3 or 4. And the cause is one, either the cerebral autoregulation has got sub-compromised, or patient has got reactive hyperemia. So there is cerebral edema, and that leads to the all these problems and later intracranial hemorrhage. So if patient had a very severe lesion to start with, he's likely, we have to be watchful. He might have, if there was lot of hypertension during the surgery or post-operative period, patient might likely to develop hyperemia. If we have used anticoagulation, that patient had atrial fibrillation also. So we have done a carotid endarterectomy, and day 2, day 3, we have started on warfarin or azithromycin. So these patients are likely to have cerebral hyperperfusion. whenever there is contralateral carotid occlusion, and if a long-standing cerebral ischemia, these patients are more likely to develop cerebral hyperperfusion. We must control the blood pressure strictly, use the anticoagulant very judiciously, and monitor these patients closely. If the patient has headache, only simple analgesics will be sufficient. If there are severe symptoms, the analgesic have to be combined with antihypertensive, anticonvulsants if there is conversion. Small intracranial hemorrhages can be treated by non-steroidal anti-inflammatory drugs or diuretics. But if it's a massive intracranial hemorrhage, it might require even neurosurgical intervention. And patients who have a small or big intracranial hemorrhage, the mortality rate is almost 70 to 100%. Cranial nerve injury, it is the most common neurological complication seen in 5 to 20% of patients, but most of the time it is transient neuropraxia. It is not a permanent damage or not an axonal damage. It recovers most of the time with expectant management due to stress, because it is caused by stress retraction and clamping. This MCQ, in the MCQ they ask, so basically all the nerves which are there in the neck, they can be damaged: vagus, hypoglossal, ancestral-vagus, glossopharyngeal, rectolaryngeal and suprarenal nerve, sinus, cutaneous sensory nerve, transverse cervical nerve, great auricular nerve, all the nerves. So in the MCQ there might be one except something, and that's why I have just mentioned. Some hemodynamic instability, that is because of baroreceptor dysfunction, or impaired autoregulation due to manipulation of the carotid bulb. If it is hypertension, it is more commonly seen with eversion endarterectomy. So this is one thing we will see whether you will do eversion endarterectomy or not. So if we do eversion endarterectomy, hypertension is more common. When we perform the procedure under general anesthesia, chances of postoperative hypertension is more, and hypertension associated with poorer outcome. Treatment is always symptomatic. Hypotension is due to carotid manipulation. This is not associated with a poor outcome, but theoretically, if the patient is having low blood pressure for a long time, he may develop thrombosis. So that is all that. So that is why it has to be treated aggressively, and treatment is called whites or DEX. Restenosis is seen in 2 to 25% of patients. Early restenosis is due to neointimal hyperplasia, which develops at the site of endarterectomy, which is within 3 years. And late restenosis is due to recurrent atherosclerosis, which generally develops at the carotid bifurcation. It should be managed conservatively as far as possible, because if we do a procedure on a patient who had a carotid endarterectomy, there are very high chances of stroke developing. So stenting is a better option in these patients, because surgery will need an interposition grafting also. And incidence of restenosis is maximum when we do a direct closure, and less than that in patch closure, and minimum in eversion endarterectomy. So eversion endarterectomy, one benefit is that restenosis is less, but the problem is that chances of cerebral hyperperfusion is more. Whether to do in general anesthesia or local with regional anesthesia. So most of the people nowadays perform this thing in general anesthesia. At least my boss or me perform it on general anesthesia, because patient is more comfortable with this. Earlier, this is the Cochrane review in 2004. Same group has again given a report in 2013, where all this thing has been thrown out of the window. So earlier they had reported that local or loco-regional anesthesia associated with less incidence of myocardial infarction, neurological events, respiratory complications. These three things have now been proven to be wrong. So now newer studies are saying that local anesthesia or general anesthesia both are same with respect to myocardial infarction or neurological events or respiratory complaint. But advantage of local or loco-regional anesthesia is there, which will remain for a long time. It allows for selective shunting, which is the gold standard, because when patient is awake, we find whether patient is developing neurological symptoms on clamping or not, and then we go ahead or do a shunting or not. So that is why when we are using local or regional anesthesia, it is associated with minimum use of shunts, and it is cost effective. But what is the problems? The cervical block is little difficult to put, and patients do not tolerate it well, and God forbid, if we have local anesthetic toxicity, it will be a problem. So most of the people do it under general anesthesia nowadays. So this is the Cochrane review, which I was talking about just now. Here they have studied 14 randomized trials in more than 4,500 patients, and they did not find any evidence that type of anesthesia influenced the perioperative outcome. They did not find proportion of patients who had a stroke or who died within 30 days of surgery. It did not differ between the two types of anesthetic technique. So their conclusion was patients and surgeons can choose either anesthetic technique depending on the clinical situation and their own preferences. So when the question is asked whether you will do it under general anesthesia or local anesthesia, we should be ready with the facts. The newer studies are showing that it is immaterial. I am more comfortable doing it under general anesthesia because I have been trained to do it in that way, and it is more comfortable for the patients, and newer studies are showing that it is not associated with any increased risk of complication. Uh, I will be doing a quick job which will require mainly 25 to 30 minutes of general anesthesia. So I would prefer to do it under general anesthesia. That should be our answer. Whether we'll do carotid endarterectomy first or CBG before that, so there are all kind of people think. Some people do it carotid endarterectomy before opening the thorax, and then they go ahead with the CABG. Some people open the sternum, harvest the lima, and take the pursing, so that if there is some hemodynamic instability, patient develops some hemodynamic instability, they can go ahead with CABG also. Some people put the patient on coronary bypass grafting, so they are very much risk-free of developing any coronary problem or any myocardial ischemia, and they do it after bypass maybe. But most of the people do carotid endarterectomy first, followed by coronary bypass grafting. All those patients who do it on pump, they open the chest, they down the lima, put the patient on pump. Uh, they open the chest, they do the carotid endarterectomy, leave the neck open, go ahead and do the coronary bypass grafting, and then when they have given the protamine, that time they close the neck, so that if there is some bleeding or anything in the neck, there is less chances of hematoma formation. So that is again, this is the repetition. Same slides I have put. So some of the studies have shown that early outcome after synchronous carotid endarterectomy plus off-pump CBG are better than those following stage or synchronous carotid endarterectomy plus CBG when it is done on pump. So if they ask whether you will do on pump or off pump, so our answer can be that our center performs the coronary bypass grafting off pump. We are comfortable, and there will be less of the handling of the aorta, so targets are good. So this patient is a candidate for off pump surgery, so I can go ahead. Otherwise, there is not much of difference between the two. Whether you will put shunt or not shunt, some people put shunt always, some people never use it. But our answer is shunt should be used selectively. It should be used in patients where it is required, because use of shunt itself also is associated with increase of stroke. So what are the indicators? Whenever patient has a bilateral disease, that patient we should not compromise the circulation, because the fact that we are able to clamp one of the carotid very easily is that we are confident that other carotid will take care. But if other is also disease, so in those patients we should try to put stent. When we have opened the artery and we find there is very poor backflow, that is an indirect indication that other carotid is not working well. So even in those patients, we will probably put a shunt. Low distal stump pressure, less than 50 milliliter of mercury. That is the first method of monitoring which was used in carotid endarterectomy. So whenever we have clamped and we find that stump pressure distal to the carotid is less than 50, those patients will have to put a shunt. Whenever there is a doubt, we have to put shunt. We are not sure that that portion is permanent, we have to put. And when cerebral monitoring is indicative, that we'll see what I mean by that, how we have monitored the cerebral function. So whenever whatever monitoring device we are using is indicative that we need to put shunt, we have to put it immediately. These are the two different kind of shunts, Argyle shunt and Purite 3F shunt. Earlier it was Purite Inara shunt. Now Purite 3F shunt is there. So Argyle shunt is a straight one. There is a radio opaque line. It comes in four sizes: 4, 8, 4, 8, 10, and 12 French. And when we are putting the shunt, we have to put a thread, do it 1/3, 2/3. The one portion goes into internal carotid artery, 2/3 portion goes below. And with the thread, we know how much we have gone in. We have a radio opaque shadow, suppose in case we need monitoring. But in this, we have to put the clamp. After putting the shunt, we have to clamp the artery again. The second one is Purite 3F, and here we have color-coded balloons. So there's one balloon, the blue one goes into the internal carotid artery, the other one goes into the distinct lower one. And we have balloon to inflate. So once we have put it in the artery, we can inflate the balloon. So there's no need to clamp, and this thing is patent, so there will be circulation also happening. So, and clamping was also not be required. And we have a T from which we can measure the distal stump pressure also. So this is the benefit of fluid 3F shunt. This instrument might be kept on the table for Viva. So this is Jarvit carotid shunt forceps. So this is round one. Looks like a cheetle forceps. It's not cheetle forceps. So this is Jarvit carotid shunt forceps. These things may be kept on Viva table, and then discussion will go on how to use shunt, how to use the steps. In the steps also, it is commonly asked in the Viva, what will be your sequence of clamping, how you will clamp the carotids. So when we are clamping, we have to clamp the internal carotid artery first, so that if on clamping there is shower of emboli, it will not go. So we have to clamp the internal carotid artery first, the external later, and common carotid last. Declamping, the process is reverse. We have to open the common carotid first, then external carotid, and last is the internal carotid. That is to reduce the shunt load, the thrombus load or emboli load. So how will you monitor the cerebral function while you are doing performing the procedure? Uh, so awake anesthesia is okay. There's some problem with this slide. No, never mind. Awake anesthesia, that is the gold standard. So patient is under local anesthesia or regional anesthesia. We are trying to we put a clamp and wait for 3 minutes. Wait for 3 minutes and ask the patient to say some words or move his limb on the side. So we assess the motor function. If motor function is fine, that means our thing is working well, and we can proceed with the clamping. If on clamping there is some problem, then we have to relieve the clamp, and we do not insert the shunt immediately. We wait for 3 to 4 minutes for that hypoxia or ischemia to subside. That is a very important thing whenever we are doing test clamping. So we have to clamp, wait for 3 minutes, and look whether any neurological symptoms are developing or not. If none of the neurological symptoms are developing, we can go ahead with our procedure. But if, God forbid, there is some neurological symptoms, we have to open the clamp and wait for 3 to 5 minutes for that ischemia or hypoxemia to subside. Then only we have to do. Then comes distal stump pressure. Distal stump pressure, 50 millimeter of mercury is indication for shunt. Less than 50, if it is less than 60, it is indication for shunt. Jugular valve oxygen saturation, I believe the figure was 45. I'm not very sure. So I will tell in third group what is the figure below which we are supposed to send. Electroencephalogram EEG is done. This is most easily available. Whenever there are any changes on an electroencephalogram, we can decide to put the shunt. Uh, so any patients, NIRS is near infrared spectroscopy. This basically finds the saturation in the subcutaneous tissues and brain. So cutaneous tissues and distance. So whenever absolute NIRS value is less than 45, or from the baseline it has fallen by more than 25, then it is an indication that that side of brain is not getting perfused well, and we have to put a shunt. Then is somatosensory evoked potential. This is not used very commonly. Last one which I should have mentioned earlier, that is transcranial Doppler. Transcranial Doppler is a very good modality to see. It sees the middle cerebral artery flow directly, and best benefit of this is it can tell us in real time if there is some emboli or some thrombus has gone. So we can plan our procedure accordingly, because it will tell us in real time that there was a shower of emboli or thrombus which have gone. So what are the steps to prevent stroke? So we'll not permit the hypertension or hypotension. So we'll keep the pressure 80 to 90 millimeter of mercury while we are clamping during the carotid endarterectomy. Sequential clamping, that means we have to clamp the internal carotid artery first, external carotid artery later, and then common carotid artery last. And releasing sequence will be opposite. Common carotid will be released first, external carotid later, and internal carotid last. So that is sequential. We have to get 100% oxygen at the time of clamping. Do the minimal aortic manipulation if it is a combined procedure, and we must use either NIRS or transcranial Doppler or electroencephalogram or one of the monitoring methods, and do selective shunting, not universal shunting. These are the strategies to different stroke. So we have covered most of the questions. Prevention of stroke. Patch or no patch? So always patch. The answer is always patch. Why? Because not putting a patch is associated with a very high risk of re-stenosis, recurrent stenosis and stroke. So that is why always we have to patch. What material will you use? Whether will you use vein or Gore-Tex or pericardium? So nowadays most of the people use Gore-Tex. If we are doing a combined coronary and carotid procedure, we can use pericardium also. But there is no difference between the results of all the three. There are multiple studies which have shown that all the three have equal results. Only thing, if we are using a vein, preferable to use a thigh vein, because ankle vein size will be less, and that vein will be associated with higher incidence of vein patch rupture. Whether you will do a eversion or non-eversion endarterectomy. So whenever the lumen of whenever the caliber is less, in those patients we'll do eversion this thing, because meta-analysis they have shown that procedural stroke or death or late restenosis or chest stroke after these things are not different. They are almost the same. So that is why it is all dependent on the on the person to person whether you will do, because there's one trial by name mentioned, Everest trial. That trial has been mentioned where they have reported that they are associated with less risk of stenosis, but patch type or endarterectomy type or anything is not associated with any influence. So practically we can use whatever we have been trained or taught. What we'll do with high carotid bifurcation. So high carotid bifurcation is a relative indication for doing a stenting. Otherwise, there are processes we have to divide the steroid process. We have to divide the digastric muscles and then find out the bifurcation and deletions. But if our pre-operative imaging has shown that patient has a high carotid bifurcation, we must evaluate that patient whether he can be served with stenting or not, because it will require a lot of retraction and manipulation, high chances of hypoglossal nerve and facial nerve palsy. So that is why high carotid bifurcation ideal is to uh, do lead to go for this thing, stenting. Then comes what are the post-operative results. So post-operative results we have already discussed when and reduce carotid endarterectomy. This also we have discussed. Post-operative follow-up, all the patients who have undergone carotid artery stenting will require dual antiplatelet for first month and single antiplatelet for lifelong. All patients who have undergone carotid endarterectomy, they will require single antiplatelet drug for lifelong. All the patients will require lipid lowering agents. All the patients will require antihypertensive. All the patients will require weight modification, obesity management, and increase physical activity, quit smoking, and quit alcohol, tobacco. And most important, annual follow-up is required with duple. Follow-up will be done with duple. So that is for post-operative follow-up. With this, we finish.
I mean, that is just so
was
good.
It was a lot of what we call
No, the
facts,
reality,
not lot of concept, lot of facts actually.
because the reality is that all things are very well laid out, and your slides are like a flashcard, you know, when you're studying for the exam. I think, cardiac surgery, the way you have covered it, carotids, coronaries, aortic valves, mitral valves, everything is evidence-based, isn't it? And there is no answer really which you wouldn't know if you go through your slides. I mean, even I am learning so much. And if tomorrow I gave a cardiac surgery exam, I think I will pass, to be honest. Because, your slides are very crisp. I don't see any confusion in the answers. So anybody's got anything to say? Is there anybody who's got any questions to ask or anything to say? No? Okay, what I'll do, because